Right. Hi, everyone. I think we're just going to wait a few moments while people filter in from the waiting room. But thank you to everyone for joining. I hope you can all hear and see us clearly. Please let us know if you can't. Fingers crossed there'll be no technical difficulties. Right, I think that's enough time. Let's make a start because I know Catherine's time is very precious. So hello, everyone. My name is Hannah Crouch and I'm the editor at Digital Health. Thank you for joining us for today's Best Practice webinar, which is going to be looking at starting a shared care record journey and how to accelerate adoption. Now, the value of shared care records have really come to light over the last year, especially during the pandemic, of course, and you will be hearing from one integrated care system that accelerated its shared record plans in order to get maximum benefit in its response to coronavirus. I'm shortly going to be handing over to Catherine Church, who's the Chief Digital Officer at Surrey Heartlands Health and Care Partnership. But before I do, I want to give you a quick reminder that we will be holding a Q&A session after she's presented. Just a note, we're going to be finishing up a little bit earlier today, around 1:10, as Catherine's got some other commitments. But we will have plenty of time for a Q&A session, So please don't be shy and get your questions in. The best place to do this, and you can do it at any point during the webinar, is in the Q&A button, at the bottom of it should be at the bottom of your screen. This is the best place. It's where I can see them. And we also have a community vote. So you'll see a little thumbs up next to each question. And if you like the look of it, give it a thumbs up and it will bump it up my list. I'm not going to stop talking, I promise. And I'm going to hand over to Catherine. So it's over to you, Catherine.
Thank you, Hannah. Thank you. And thank you ever so much for giving me the opportunity and come to talk to you this afternoon around Surrey Heartlands and our journey to get our shared care record up and live. So could we put the slides up, please? Excellent. And as we do that, I'll just introduce myself. So Hannah, as you said, I'm the Chief Digital Officer for Surrey Heartlands. So what does that mean? So I'm a joint appointment across social care, so Surrey County Council and our health economy. So genuinely, my role is to bring health and social care together through digital. And it's to look at and engage with our partners to find the really big strategic projects that are going to use data and technology that are going to be designed from a customer-centric perspective in order to improve outcomes for people. And in that definition, a shared care record could not be more central to bringing health and social care together. So that's my job. What I'm going to do over the next 15 minutes or so, to give plenty of time for questions, is just to give you a little bit of an introduction to our shared care record. So what is it and what does it do for us? I'm going to explain a little bit around the complexity of our system. So I'll give you a quick tour of our partners and participants. And then really, rather than me talk for that 15 to 20 minutes about how we've achieved what we've achieved, I've invited some of the leaders and the users, the people who've really helped drive our journey forward, to speak in their own words and share with you their experience of what they've done, what we've done, and what they think is important to get to adoption. And then with the last couple of minutes, I'll just talk to you about our next steps. And so if we can just move on to the next slide, please. Excellent. So what is our shared care record? So it's a shared care record. So it is a digital platform, a solution that allows professionals to access and see data securely that comes from across a range of multi-professional organizations. And what I've showed you there, what we've put on the screen is a little screenshot of the Surrey Care Record and how it appears on a practitioner's screen. And this is really, really important to us. So what's really important is that we're able to securely authorize access for authorized healthcare professionals to records from other parts of the health and social care economy. So what you can see on your screen there, so let's say an example that you're a GP working with a patient, so you're about to prepare for a consultation, be it face-to-face or a virtual consultation nowadays, or you're preparing for that. And this is a view that you would see from within your EMIS platform. So you're within your patient's record and you would click on a tab within that record and this would launch the Surrey Care Record. So what the Surrey Care Record then does is it then collates data from across other parts of the organization. So from our mental health providers to discharge data, documents, real-time documents, medication data, for example, from the acute sector, but then also records from Surrey County Council and our mental health providers. And that data is then presented in a really easy and intuitive way for professionals to be able to navigate. So there's a couple of things there that are really, really important for adoption. Is one, how people access the data. So making sure that the way you access your shared care record is integrated into the administration system. So either to the EPR or the PAS, so that it is really easy. So professionals don't have to go and look up a different system and search for a patient. There's absolute clinical risks in doing that because you might get a mismatch. But it's also, if you have to log into a different platform, then it's really difficult to get that engagement with providers. So when it's contextually integrated, it means it's really, really easy to find. From a security perspective as well, it means that you're actually using the security mechanisms and the sign-in mechanisms from your patient admin system or your EPR to make sure that only the right people are able to see that data. So that's really important to us. So how you access it in terms of the technology, the Graphnet platform is directly integrated either into the information engine or of your provider or directly into EMIS, and it takes that data and it makes sure that that data is actually matched accurately, so all the patient records are matching up, and it does that and for us, we're doing that in real time. So what your GP sees when they're actually logging on is real-time information. So it's the latest information. So we're making sure that we don't have an information lag. So that's a bit of an overview of the product. In terms of Surrey Heartlands, I'm 1 year actually this month into the NHS and into the public sector. So I had no idea that the NHS was anywhere near this complicated. It was a blue badge and it was my GP and everything was simple beyond that. Well, that's far from the case. So in Surrey Heartlands, what you can see is we have a footprint of circa 1.2 million residents. We've got 4 acute hospital trusts working with us and actively engaged in the Surrey Care Record, sharing and viewing data. A mental health trust, which is doing the same, 2 community providers, an ambulance service, community pharmacies, 104 GP practices, which now of course are PCNs as well, so around 25 PCNs, and we have 95% of our GPs signed up to actively sharing and accessing the Surrey Care Record, which is exceptional. The County Council, who've been a huge supporter, and on our roadmap, we are integrating with hospices so we can offer a really rich experience around end of life, bringing together multidisciplinary professionals around end of life care. And during this year, we'll start to look at care homes as well. Clearly, there's some real complexities around the care home market. So that's the footprint, that's the functionality. In terms of how we got to go live, so this project had been going for a couple of years for us. And it's fair to say that we had a couple of false starts because this is complicated and it's important. So I've just explained the number of providers and the complexity of the providers, the sensitivity of really making sure that we get the use cases right, that we get the information governance right, that we really sell the benefits of our proposition. So we'd had a lot of discussions, a lot of engagement, and of course with the with COVID coming around, and with also a real focus on that data sharing as our system has come together, we've really accelerated over the past year. I just have to be really careful there to say that we did not use any copy notices. So we've gone through absolute information governance, which is one of my speakers coming up. So we had been through a process of deep engagement of really setting out our data sharing agreements, our DPIAs, et cetera, to make sure that what we have is robust and secure and will really serve us beyond, I hope there's a beyond coronavirus. So I'm going to now bring in a group of colleagues to actually talk through the how we did it. And the first person, if we could just move along one slide. So one of the key people who's really helped us gain that momentum and that traction across the system is my boss. So Dr. Claire Fuller is the lead for Surrey Heartlands ICS. And she has been an enormous supporter, huge, enormous supporter of the Surrey Care Record. And of course, in her position, she has an enormous amount of influence, but she's also a GP, so she's a user of the system. So if we could hear from Claire, please.
So to gain traction behind the Surrey Care Record, I think it's really important to identify why we're doing and what the benefits are. So the most important gain for me as a system leader, but also as a GP and as a resident of Surrey, really it's about patient safety. So having a single record that brings in every aspect of an individual's care, avoids the duplication, and means that, so my father, who has a myriad of very complex needs, only needs to tell his story once, and I can be assured that wherever he goes, that people are aware of what his past medical history are, what his current medications are, and we can avoid harm inadvertently being caused through lack of information. So the traction is gained by the understanding of why it's important and what the advantages are from pursuing a project.
That's fantastic. So as well as making sure that we get the use cases right, so why would a clinician in A&E find this information important? Why would a social worker sitting in a district office in one part of Surrey find this information important? So really working with our providers to understand and articulate the use cases is incredibly important in terms of engagement, but also having the support from the senior leadership of your system, and having wonderful people like Claire who really will advocate for us when it gets a bit tricky has been massively important. So the next bit I'd like to just move on to is information governance. And we did have a couple of goes at this, and I'll just come back to the fact that it is so important to get this right, to be absolutely critically clear on what information is being shared, what our legal basis for sharing that information is, making sure that patients and the residents of Surrey are informed and know that the Surrey Care Record is there, and that we have mechanisms for people to opt out is incredibly important. And by having that really robust, engaged IG that demonstrates this solidity of the project and really demonstrates the respect that we have for clinicians and the respect that we have for patients, and how critical it is to get the basis on which we share information right. So if we could just move on a slide and hear from Dan.
Information governance is a key enabler for integrated system working and ensuring the best possible care is provided to individuals. When taking forward a shared care record system, I'd recommend there's early engagement with the IG leads and the data protection officers from the various partners, as they'll have the best knowledge of the systems the organisation uses and the data within these. I would also recommend these people are involved in developing an IG management framework and data sharing framework that supports a range of activities, from direct care, also covering secondary activities such as population health management. It is also very important for the partners to be involved in agreeing robust processes for monitoring usage of the shared care record system, as these need to be in place to give trust to the public and partners that all usage of data is safe, lawful and effective.
Fantastic. What we've done is we have a data governance group that sits to support the Surrey Care Record, but also other data sharing projects, and that has representation from IG professionals, but also clinicians as well. So we make sure that we're really pragmatic, we're really practical, and we have an absolute clinical engagement for the data that we share. And in fact, the clinical involvement in shaping the shared care record has been absolutely vital. And in fact, speaking of clinicians, we're going to move on a slide now. And I'd like us to hear from our CCIO, who is Dr. Andy Sharp, who is a GP. And GPs notoriously, or some of them, notoriously difficult to get people to change the way in which they engage with things, and also really, really important to make sure that we have the support for professional bodies and associations such as the LMC, who again have been really helpful. So we've worked so closely with them throughout this whole process. But let's hear from Andy to say what information is useful to have in the shared care record, so that people find it a useful addition to their clinical practice.
It's vital that you get really unique, useful data sets into the record. Otherwise, there's no point people clicking on the single sign-on. If you can make sure that they're going to get access to some form of data that's going to allow them to make a completely different clinical decision, you'll find that they're beating a path to your door. For myself, I know that the GP record holding all of the hospital documents and letters is really so crucial. And this is something that the hospital doctors really don't usually have access to when they're seeing someone in casualty. So if you have someone, where I work, the cancer hospital is over the border from where the casualty department hospital is based. If you can get access to all of their cancer care letters into a shared care record, and you know that the casualty officers can get that with 2 clicks of a button, that's going to allow them to make far more robust decisions and actually give better care to the patient.
Brilliant. So absolutely critical there. Another use case that I just wanted to bring in, because I'm also working on our Think 111 First project, which is aimed at reducing the amount of unheralded people arriving at 111, arriving at A&E departments. So there we're looking really at, we delved into a lot of detail as to who arrives in A&E and why people present at A&E. And we found that there was such a large number of people with mental health issues arriving at A&E. And without something like a shared care record, not a summary care record, the shared care record, they're really different. And I'm happy to go in and explain the difference that you can access at A&E. Then actually, if you see somebody and you can access their shared care record and you can see that they have a mental health social worker, you can see that they are under the treatment of a mental health trust, for example, and they also will have a helpline and some information and support. Just makes it so much easier in A&E to manage these types of patients who arrive. So really, really important to think through those use cases and get the right kind of data in there. So for us, real-time data, and we're just working on getting documents. So documents from hospitals and from GPs themselves into the shared care record. So that's the next stage of our development. The next section here is, I wanted to let you hear from some of our users. So we're going to have 3 Vox Pops now. The first ones are from our Mental Health Trust. And Melissa is the Chief Clinical Safety Officer there, and is also a huge user. And of course, Elizabeth is an occupational therapist. So just to hear from people what it actually feels like. And of course, again, because the theme of this section is about adoption, if you can get your really kind of engaged users so happy to be advocates on your behalf, with all of these people are advocates on our behalf. So every time there's a clinical meeting, every time we've got an MDT meeting, people are talking about the shared care record, then that really helps to boost that adoption. So let's hear from Melissa and then go straight on to Elizabeth.
I think there's 2 key essential components when we talk about the adoption and utilisation of the Surrey Care Record. The first for us was absolutely assuring the clinical safety. So we approached the clinical safety risk assessment to consider both the viewing and sharing of information. And we made sure that we had a dedicated work stream to demonstrate compliance with the safety standards. For each phase of sharing mental health information, we have made sure that we've ran workshops with our technical and clinical colleagues to explore any new hazards, and we generate controls to address any areas of risk. And we update our hazard log and our clinical safety case report. So this really gives our clinical colleagues the assurance it's safe to use. Another area for us to support the use of the Surrey Care Record was around our single sign-on design. So we provide care across 2 ICS areas, which means we have 2 shared care records to partner with. And we really wanted to make sure it was a seamless approach to access the right shared care record within our electronic patient record system. So we designed a protocol that runs a report that looks up the patient CCG, and it will then launch the URL to the right shared care record. It's a simple design, but it makes a real difference and takes the hassle out of searching for the right shared care record.
I think it's absolutely brilliant. It's very easy to use and navigate. Information opens up very quickly. The information is comprehensive, really, really useful, and brings together physical health, mental health and social care information, which is so useful. I'm involved with a patient in my service who's being investigated for possible young onset dementia, and through Surrey Care Record I discovered that since being referred to us, he has also been seen by a neurologist and has had a brain scan done, which is really useful information for my team, because we can liaise with the neurologists and coordinate his care.
I don't know whether Elizabeth has finished. For the benefit of time, we'll assume that Elizabeth has finished there. And the last person I'd like you to hear from is Tony Carney. So Tony Carney is one of our great advocates in adult social care. In fact, adult social care were the first partner to go live with the Surrey Care Record, which is absolutely amazing. One of the things there that's quite important with adult social care, and what was really useful for us, is the Graphnet platform and the social care and, in fact, children's services platform that is used by Surrey County Council are from the same provider, so Liquid Logic and System C. So that just meant that we could beat the providers up, the technical providers up, and really get them to think through some of the technology engagement and the data cleansing and the technical parts of that. So that was really helpful for us. But a few words from Tony, if we could.
We are big users of the Surrey Care Record in adult social care. We have single sign-on through our Liquid Logic adult system, so that makes it really easy for people in adults to access the system. And typically they will use it to access GP data that they would ordinarily have contacted the surgery about, either telephoning or writing to the GP. And they're able to access the record online quickly and obtain the information that they're looking for example, updates on medication, or perhaps somebody's health condition in connection with an occupational therapy assessment. And the benefits for the staff are that they can do that really quickly. They're not disturbing the surgery or the GP, but also they're getting information for the resident promptly and can conclude their inquiries really quickly. So it's been really valuable for us to use the Surrey Care Record in that way.
Fantastic, excellent. So massive support from adult social care, and in fact in our roadmap at the moment we're replicating, so we're doing the children's version of the Surrey Care Record, and we will be going live with that children's version in the next 3 months. So just to close up, mindful of time and wanting to give time for questions, if we could just move on one slide, and it was really to say what's next for us. So continuing with our document sharing, bringing on the hospices, bringing on children's services are the things that we're doing at a local level. But when we signed up to this, we signed up to a regional, we signed up to a national strategy which had a local healthcare record. So we are part of the Thames Valley TVS LACRA local healthcare record programme. And so what that means is that we're part of a bigger club, and that bigger club covers the 6 ICSs with covers the 6 ICSs that you can see on the map there. So our plan is to flow our data into TVS. So we're just going through the information governance and the information governance and the engagement across partners to make sure that we have that absolute total support to take the next step that we always knew we were going to take. Now's the time to do that. And then when we do that, certainly for our mental health provider, being able to flow patients across the boundaries of us and Frimley, and patients do move around. So our admin boundaries are entirely artificial. People do move around, and with the right permissions in place and the right controls in place, then it is absolutely right that we're able to flow that data to enable our residents to be looked after when they move into different care systems. And a final few words for me before I open up for questions, if we could move on to the next slide and final slide here, is the next step for us. And this is, again, one of the reasons why we chose the platform that we chose, is that once we have all of this data in one place, it really allows us to use that data. And that, again, is another next step for us, is that we can leverage that data and create some really, really powerful population health insight. And the platform comes for us, comes with some PHM capabilities and analytic capabilities. And that's the next stage for our development. So using the data that we've created, all of the work that we've put into bringing our data into one place, it's then depersonalizing that data and using that data in the next stage of our development to really support hyper-localized, so GP level, PCN level, ICP, ICS level, but then also on a wider regional footprint. So that's probably it for me. I've probably got about 15 minutes for questions.
Amazing. Thank you so much, Catherine. That was really interesting. Really fascinating to hear from users of the record as well, which I think sometimes gets lost. You sort of focus on the go live and things like that. So it's really interesting. I will stop talking so we can rattle through some questions. First one we got, which I can answer very quickly, is will the slides be shared? And that's yes. Those who want to see the slides, I'm sure we'll be able to share them. Another question we've had from Matthew is about intrigued to know whether this format will be available to people in other local authorities. So for the example, will the records be available or able to be accessed to medical professionals should, say, someone be on holiday in Yorkshire or something like that?
That is a really good point. So that is a really good point. And because what we do is we enable access to the shared care record through authentication into the core system. So if you're a social worker and you use Liquid Logic, you will access the shared care record through Liquid Logic, that is absolutely the right and safe way to do it. So it would then be up to our providers, so say Surrey County Council, if they allow their social workers to access patient data and those records, then I'm saying this, I'll probably have to go back and check with Dan, but it is not up to us to police that access, it's up to the providers. So we sign up with them, the information sharing agreements that we sign up with them makes it very, very clear that they are responsible for the access to the data in the same way as they're responsible for access to their own patient data.
Brilliant. Another question we had is about, are you planning to open up patient access to their records where appropriate, obviously? And are there any plans for interoperability with third-party apps?
Yes. That sounds to me like a Graphnet question, so I think we've got a mole from Graphnet in there. So yes, that's absolutely the next stage for us. As a system, we are working on our strategy for patient health record and patient portals. And as somebody who is really new to the NHS, I would be really bewildered if I was offered an app for a long-term condition, and then I was offered an app to log into my GP records, and then I had something else for secondary care. So what we're doing as a system, we've got a really strong digital community, which is amazing, is we've all agreed to design this together. So I don't know yet where the right point of access will be. The NHS app is kind of looking quite attractive, NHS login. So we're just designing that strategy now. And of course, the most important thing there is, what do people want? So what do I, as a resident, how many apps is okay for me? What information do I want to access? What information do I need to access? And how would I like to do that? So we're at the early stages of our journey. And if there are people out there who are further ahead than me, then I would really love to hear from you and learn from your experience.
You mentioned Graphnet because someone just said in the chat they missed the start of the session and asked a system that was selected by Surrey Heartlands. It was Graphnet, wasn't it?
It was, yes.
I didn't want to answer it in case I was wrong, but yeah, so it's Graphnet.
Yes.
So next question we've had is about IG agreements and how much of a challenge it was to get them in place with such a range of organisations. And are there any kind of lessons learned that you could share?
Yes. So it was difficult because it should be difficult, because this is really vitally important to get it right. And I think so the lessons learned are, I think, as Claire said, so being really clear about the use cases and being really clear and getting clinicians on board. So this should not be a technology project. It is a data integration project, and the tech and getting the data right is a little bit tricky. And it should not be an information governance. It should not be an information governance project. Both of those two things should be, and I'm using the word very deliberately, should be slaves to the clinical need and the patient need. So if you've got the patient need right, and we did a lot of engagement with Surrey through our citizen ambassadors and through our digital panel. So we did a lot of engagement. Is this what the people of Surrey want? And then it's clinicians driving this. And if you've got clinicians driving it and really clear use cases, then IG colleagues are absolutely brilliant, and ours are brilliant. So if anybody wants to reach out to either myself or Dan, we did some really cool things around having overarching information service agreements in place. We put toolkits to help people step through and understand what they wanted to share and how. We held people's hands a lot. And actually, as a central team, we did a lot of the work ourselves, recognizing that we were doing this at a time of a pandemic. So whilst everybody knew it was important, we were not the top of anybody's list, to be honest with you. So we had to do a lot of the work ourselves, and that's equipped us with a lot of insight that I'd, again, be really happy to share.
Amazing. And one kind of aspect of any shared care record is GPs, who are often quite information rich. How did you kind of any thoughts about how to engage with GPs? And kind of someone's mentioned, Tony, that they've mentioned they struggle to engage with GPs. So what advice could you give?
I think you have to put on your prettiest party frock and go out and sell and seduce. So the things that we did is one, we were really, really clear about the use cases. So you heard Andy Sharp, you heard Dr. Andy Sharp. So actually the things that we are doing and the things that we want to do are driven by that clinical need. What would be useful to you, Andy, when you've got a patient in front of you? What's the information that would be useful? So having 4 or 5 GPs who are really that have got the time and are interested in a digital model of health. So having that very small number, the more the better. But if you're struggling with engaging with all GPs, then let your energy flow to where the people want to be. And you'll find that those GPs are probably quite influential as well. The other thing that we did is we engaged with the LMC early, and we addressed the concerns of the LMC and of the GP's data protection officer. So worked really, really closely with them to actually establish the need. And all of our GPs, quite rightly, will look to the LMC and they will look for guidance. So working with them and working through a rigorous process with the LMC of making sure that we've got this right is really important. So once you've got that and you've got a few GPs, then we went on a campaign. So as I said, I put my best frock on and we went out to seduce. So we did webinars, we did drop-in sessions, we've got videos, and we actually work very closely with our primary care commissioning team, who are exceptionally brilliant. So they have the day-to-day relationships with some of the practices. And then we learned quite a bit through admin. So getting the information sharing agreements signed, using Adobe signed instead of sending emails. So there's some practical things that we've done, again, which now as we're going to enrich and go on the next stages, we've got all of that. So we can just say stage 2 of the campaign, have we done the user engagement right? Have we really worked through people's very, very valid concerns? So listening to concerns is really important. And then we can put the show back on the road.
Lovely. Another question come through from Dominic is, are you using or do you plan to use My Care Centric, the personal health record? If so, experiences, including sign-up process for citizens?
So I think that comes back to the question before around patient portal and personal health record. We're just at the beginning of that journey. So we're just at the beginning of that journey. So I don't know what product we're going to use yet. So we need to get the user insight right. We also, as I say, we're working across our providers. So, for example, our acute providers have got information that sits in their portals that's really vital for their operating model. So we're not going to replicate that. So how do we actually architect a solution that's elegant for patients, that means they're going to use it without, and really bringing in other providers, so that we've got a portal that is really useful and helps people navigate our incredibly complicated health system. So I don't know yet, but if anyone else has experience, I think Manchester have done quite a bit with it. So again, if there's a community of expertise out there, I'd love to be part of it.
A question from Robin, who said it sounds like a great project, but for balance, what didn't you think didn't go so well, and what are you still struggling to get right, do you think?
Yeah. I mean, this is really it's complicated stuff. And in fact, when Claire interviewed me to take this job last year, one of the main reasons I took it, and I'm from a commercial background, was that she, you know, she had got the alignment of people to go on this journey. And I was like, really? Because in banking, that would never happen. That would never happen. Get to the bank, go, yeah, I'll give you my mortgage data, and I can have your if there's anyone from HSBC here, sorry, but that ownership of the customer. So everybody coming together as a system and saying they wanted to do it was one of the main reasons I took the job. So it's been such a delight to actually see that through. So I think one of the mistakes we made was was at the beginning to see it as a technical project. So that's the biggest mistake anybody can make, is that the technical integration is important, but actually the use cases, the engagement with stakeholders, getting things right from an information governance perspective, working with the LMC. So really, so that's the much more important bit. The data's dirty, all data's dirty. The technical integration it has its challenges, but the Graphnet team, actually, to give them a bit of a plug, were brilliant in helping us with that. But start with the end state, start with the use cases and work backwards from there.
Yeah. And one question that I think is quite interesting, can the residents of Surrey view and edit their own summary care record? Is that possible?
So I'll just be really clear, it's not a summary care record. A summary care record is an NHS digital product that is available to GPs only, or people with smart card access. So very, very different proposition. And it comes back to the patient portal and personal health record. So absolutely, the intention is to open up a patient portal and a personal health record and enable people to really, really participate and drive their own care. That's the next stage of our development. So we're not quite there yet, but that's our main objective for this year, is to enable that functionality. Because this data belongs to us. It belongs to the residents of Surrey. And I think it's really important that they get to participate in that.
Easy. I'm just making sure I'm going through all the right questions, because there's so many coming through. One is about data collection. Can the data collection system be integrated with other software that can also be used for information monitoring?
Yeah, so it depends on how you do it, is the answer. So I can only talk about the architecture of the Graphnet platform. So what that has then, as part of the components of the Graphnet platform, they do have an architectural component that allows you to open up and bring data in, so ingest data in from remote monitoring apps, for example. But quite a few platforms do that now. So there's quite simple technical APIs. And in fact, with the Graphnet platform in particular, the ability to bring that data in and then view that data through the personal health record is there. But this is all quite new. This is all quite new to the NHS and to healthcare systems. So it's evolving really fast, but there's different ways of doing it. And certainly the architecture does allow it. But for me, it just comes back to, is this the right thing for people? So if I'm monitoring my own healthcare and sending data electronically into a platform, then I expect somebody to be doing something with it and looking after it. So it's not just, again, it's never about the technology. It's about that whole clinical model of care of actually, if we are going to use remote monitoring or self-monitoring, then actually what's happening to the data and who's seeing it, and what are we doing as a result of it.
I think we've got time for one more question. I know you've got to sort of shoot off afterwards. Were there kind of any other partners involved other than providers and local authorities? There were things like the academic health science networks involved. No, not for us on this one. I think we've got enough
I think we've got enough participants to deal with there. I saw in the chat, I saw a question pop up around care homes. And again, that is on our plan for this year. So as most people will know, NHSX is extremely keen, if not mandating, that all systems have a shared care record by, I think it's September 1. And there will be a minimum data set that needs to be shared into that shared care record. Care homes are not part of that at the moment. We're fortunate in that we were an early phase of shared care records. So we were funded at an early stage to do this as part of our LACRA program. So we've got a bit of a head start on some other areas. So care homes is next phase for us. So as you can imagine, there are a whole set of information governance, clinical and technological problems. So care homes don't come with a neat one, they don't use the same platform. So we've got a whole range of disparate places to integrate to. There's the whole thing about making sure that only the right people see the data that they need to see. And then there's the whole thing about maintaining that the access to that data in environments where you can have quite a high turnover of staff. So it's the next level of complexity. But actually, when we think how vulnerable and isolated people can be in care homes and how important it is for people to be able to, multidisciplinary professionals, to be able to offer that digital health model to people in care homes, because they can no longer come to hospitals, or we don't want them to come to hospitals and GPs, then it's really important to think about that. But that's the next level of complexity. So we're not done yet. I just don't want anybody to go back to Surrey and go, great, you're putting care homes on. No, we're not. We're thinking about that next stage of how we do so in a way which is safe, which meets information governance and our clinical guidelines. I've probably got time for 2 more questions because I'm really enjoying my.
Well, you shouldn't say that. I could keep for too long now. Let me go quick through some of the questions then. So you didn't say about care homes, because there's quite a lot. To be fair, there is quite a lot of care home stuff. Can you advise on how you're able to share documents out of GP IT systems? Is one question.
Yes. I can. So we have a local solution here that we are putting in place. And again, we're just going through the implementation of that because there's some complexities there. So we're using a product called Docman Share. So Docman is used within GP surgeries, and we're working through. So we've got the information governance in place, but we're working through the practicalities of how do we enable GPs to choose which documents they want to share in. So anybody who's on this webinar who has a personal health record that is showing patient documents from GPs will have been through this same process. So what you don't want to do is just open up all documents. So GPs need to have a way of filtering the things that are right. So we're going through that process with GPs at the moment. So that's the product we're using because that's the most simple. Of course, I think in the next iteration of so document sharing solutions move along really quickly. And of course, there's things that you can share from EPRs, but for us at the moment, it's Docman Share. So again, that's another project that we're in the middle of planning at the moment.
Have you got time for one more, or do you have to go?
Yeah, let's do one more.
This one's about mental health. So does the Shared Care Record support mental health provision and collection of data required for AIPT support received?
So yes, it does, because you heard from our mental health trust. So 2 of our speakers were from our mental health trust. So yes, it absolutely does. And I'm going to plead total ignorance as to what that acronym was. Sorry, I don't know. IAPT. If somebody wants to drop me an email, then I can tell you. The answer is probably.
Yeah, I'm saying I think we'll wrap up now anyway. But what we can do is we can pass on some of the questions that we've had coming through. And if you want to answer them or sort of submit your answers, we can do that. But I think we'll wrap up now.
Improving access to psychological therapy.
Oh, there you go.
Yes, I think so. Yes, Linda, I do think so. And there's a question there around privacy issues. Ours is an opt-out model, and that was done after extensive consultation with Surrey residents and with clinicians as well. So it's an opt-out model. We have privacy notices in GP surgeries, on GP websites, on the Surrey Care Record website itself. And with each of our providers, we have a process in place. So if somebody opts out, they can opt out either from that bit or from the whole thing. And then, of course, the national discro system has an opt-out process. So if you opt out at an NHS level, and then because our Surrey Care Record is integrated with the spine, we would pick that up as well.
And is there kind of a consent process involved? I'm sorry, I'm just asking a question now.
Opt out.
Opt out it is. Sorry,
yeah,
I should have
an opt out process.
Yes,
Yes, absolutely. But we do absolutely everything we possibly can to make sure that people know but it's all about selling the benefits. It is absolutely about selling the benefits. If something happened to you and you ended up in A&E, would you want somebody to know this information? So it really is about that engagement with the public. And I really see this as a conversation. This is one of the most important conversations as we move to a digital model of health. This is the most important conversation that we can have with residents, is around data sharing and building that trust in us as the NHS or health and social care, to really give people that trust and confidence that we will treat their data with respect, we'll do the right thing with it, and we'll keep them informed and engaged. And I really must go, but that I really enjoyed the session. Thank you.
Yeah, well, I think we've gone through most of the questions anyway, but thank you so much for your time, Catherine, really appreciate it. Just before we go, one quick note to say we've got some fantastic events and webinars coming up. Our main one is Rewired on the 15th to 19th of March. Please do get yourself registered. There's some fantastic summits. We've got lightning talks. We've got Pitch Fest. The list goes on. I think we've got 300 plus We've got 300 plus speakers, there's 10 summits, there's round tables, you know, there's 5-minute lightning session talks, which I think I've already said anyway. But please do head over to the website, check out the programme and get yourself registered. As I said, it's March 15th to 19th. It's not too long now. But yeah, a shameless plug over. So I will stop sharing now. But thank you to everyone who's joined us for today's webinar. I think Catherine's had to leave, so you're stuck with me. But thanks to everyone for joining, and that concludes today's webinar.